We come now to our last lecture, last topic for this year, last topic for biochemistry for you. I'm sure you're smiling now as you hear this, but this topic is very special. It's an easy topic, but it's a very important topic. Okay, so I'm sure you will enjoy listening to this video and you will find it very useful. The objective in this lecture is to talk or to define diabetes, to differentiate between the two types of diabetes, to know the consequences of diabetes, and to identify diabetes prevention methods. But what is diabetes first? Diabetes is a group of disease. It's not one disease. And what is common about this group of disease is hyperglycemia. So what is hyperglycemia? It is the elevation of fasting blood glucose caused by a relative or absolute deficiency in insulin. So either there is no insulin or there is little insulin. It's a very serious disease because it can lead to blindness, amputation, renal failure, heart attack, and stroke. So people can actually die from diabetes. So most cases of diabetes, I'm sure you remember, we've seen Modi in Mole 1, if you remember Modi disease. We're not going to talk about this in this lecture. We're going to talk about the two types of diabetes mellitus, which are type 1 and type 2. Type 1 used to be called insulin-dependent diabetes mellitus, but no one used that name anymore, so it's called type 1 now. And type 2 used to be called non-insulin dependent diabetes mellitus. To understand this lecture and to understand the biochemistry of diabetes, you have to understand one thing. You have to remember the role of insulin. What is the role of insulin in our body? If you recall from previous lectures, we talked that insulin is an anabolic hormone. Insulin signals the well-fed state in our body. So when we have insulin in our body, its role is to act against hyperglycemia, to restore normal blood sugar. So it's going to do anything it can to reduce blood sugar. So what does insulin do in our liver and muscle? So in order to reduce this hyperglycemia, it's going to ask the liver and the muscle to start storing glucose as glycogen. So remove that sugar from the blood and store it as glycogen. In the muscle and the adipose, insulin is going to increase glucose uptake by increasing the number of GLUT4 transporter. So it's going to make more GLUT4 transporter available on the cell membrane in order to facilitate the entry of glucose to the muscle cells, to the adipose cells, again to try and correct hyperglycemia. Insulin is going to ask the liver to stop making glucose. We have hyperglycemia, there's no need to make more sugar. So it's going to inhibit gluconeogenesis, the formation of new sugar, and it's going to inhibit the breakdown of glycogen, which is stored in the liver. So this is the function of insulin. Try to reduce hyperglycemia. It's going to do anything it can to stop the body from making new sugar, gluconeogenesis, or breaking glycogenolysis. On the opposite, is going to increase glycogen storage in order to remove that sugar from the blood. And another way to remove the sugar from the blood is to send it to the muscle and the adipose by making more GLUT4 available. So if you can grasp this concept, and if you know that in diabetes we have little and no insulin, then it's easy to understand now the biochemistry of diabetes. Also, you should remember, what does insulin do in lipid metabolism? Because not only hyperglycemia we have in diabetes, we also have dyslipidemia, and we also have we can have in severe cases formation of ketone bodies, which can lead to ketoacidosis. So what does insulin do on lipases? If you remember, we have two types of lipase. We have the hormone sensitive lipase, which what does it do? It degrades lipids in adipose tissue. So it's involved in mobilizing the stored fat. Insulin, remember, it's anabolic hormone. It's a time to make or break things. It's a time to make things, right? We don't want to break, so we don't want to mobilize the fats. So insulin will tell the body to stop breaking fats. It's anabolic, okay? Also, insulin affects another lipase, which is the lipoprotein lipase. Insulin will activate this lipase, lipoprotein lipase. What is the function of this lipase? It is to degrade lipoproteins. So this lipase, lipoprotein lipase, will degrade chylomicrons, therefore releasing fatty acids. So the chylomicrons will carry the fats that is coming from the diet, because again, insulin is signaling well-fed state. We're eating, we're having lots of food, we have all these fats in our chylomicrons. Now we need to break those chylomicrons to release those fatty acids, having them entering the adipocytes where we are going to form triglyceride there. So again, this is the anabolic effect of insulin. So it inhibits hormone sensitive lipase because we don't want to mobilize stored fat, and it activates lipoprotein lipase because we want to break all this fat we're getting from the diet in order to store it inside our adipocytes. And this is how we get fatter, by having more triglycerides stored in our adipocytes, and the adipocytes will get bigger and bigger. So, having this in mind, let us see the story of type 1 diabetes. Type 1 diabetes is an autoimmune disease, and we have absolute deficiency of insulin. Means there is no insulin. So why there is no insulin? Because of an autoimmune attack on the beta cells of the pancreas. So our islet of Langerhans will become infiltrated with activated T lymphocytes, leading to what we call insulitis, and this will gradually kill the beta cells, and we will not see any symptoms until 80 or to 90% of the beta cells have been killed. So once we have reached this stage, the pancreas will start failing to respond to ingestion of glucose. Because what is the response of the pancreas to glucose? Secretion of insulin. But with only 10% remaining of the beta cells. Can we make enough insulin? We cannot make enough insulin, and therefore the symptoms will appear. But eventually all the beta cells will be killed and there will be no insulin. Therefore, these patients require insulin therapy. That's where the name used to be insulin-dependent diabetes mellitus, because those patients required insulin. Okay, you cannot just give them a drug that will lower their blood sugar. You need to give them insulin. This diagram illustrates how type 1 diabetes develop. On the x-axis, we have years of autoimmune destruction of beta cells. So it takes about 10 years to completely destroy the beta cells. And what triggered this destruction? There is an immunological trigger. So an exposure early in life, during the first few months of life, and this is the theory, that there is an initiating event. So there is exposure to a virus or some toxic material which start the process of beta cells destruction. To have this, you have to have some genetic predisposition. So there is a genetic factor in type 1 diabetes, and we will talk about this in more detail. So what's happening here? There is a slow beta cell destruction. Over a period of years, the beta cells will be destroyed, resulting in less and less insulin. So the y-axis shows the insulin secretory capacity. So over the years, as the beta cells are being destroyed, they are producing less, or the pancreas is producing less and less insulin. And when 90% of the beta cells are destroyed, this is the clinical threshold, this is where the symptom appear. So as I said, you need both a stimulus from the environment and genetic predisposition to allow the beta cells to be recognized as non-self, and the body will start attacking them. Why there is genetic determinant? Because they found that in monozygotic or identical twins, if one of the twin develop type 1 diabetes, the other twin will have a 30 to 50% chance of developing the disease. If we compare this with type 2 diabetes, which we will talk about later, we will see that the genetic influence is much stronger in type 2 diabetes, because in monozygotic twins, if one has type 2 diabetes, the second will eventually have type 2 diabetes. How do we diagnose type 1 diabetes? So it starts usually in childhood or puberty, so early in life. It appears as sudden symptoms of polyuria. So for those of you who are not familiar with the term, poly mean many or frequent, uria, urination. So there's frequent urination. Dipsia is thirst, so excessive thirst. Polyphagia, excessive hunger. And these symptoms are often triggered by illness. Any illness such as an infection can aggravate those symptoms. There are other symptoms such as fatigue and weight loss. How do we diagnose it? We do a fasting blood glucose. If it is above or equal 126 milligram per deciliter, it means that the patient has diabetes, because the normal fasting blood glucose should be between 70 and 99. And by fasting, I mean when you take the blood sample after 8 hours of fast, or by measuring the glycated or glycosylated hemoglobin concentration, and that should be, for a diabetic patient, should be greater than or equal 6.5 milligram per deciliter, because the normal glycated hemoglobin should be less than 5.7. What if a patient has a fasting blood glucose which is less than 126 but above 99? So between 100 and 25, if you have a patient having a fasting blood sugar between 100 and 25, he can be diagnosed as having an impaired fasting blood glucose, and he's considered as pre-diabetic. Therefore, he has increased risk of developing type 2 diabetes. And luckily, at this stage, you can do something to prevent that patient from developing diabetes. So, what are the metabolic changes in type 1 diabetes? So, all the metabolic changes are the result of insulin deficiency, which is going to affect mainly those three tissues: the liver, muscle, and adipose. So, we will see hyperglycemia and formation of ketone body or ketoacidosis, which are the hallmarks of untreated type 1 diabetes. Why hyperglycemia? Because we have no insulin. Okay, there is nothing to tell the liver to stop making glucose, so we're going to have an increased hepatic production of glucose via gluconeogenesis. Again, there is no insulin to let that glucose enter the muscle cells and the lipid cells. Therefore, we are going to have a diminished utilization of the glucose by the muscles and the adipose tissue. We call this peripheral utilization. And also we have ketone body formation. What are ketone bodies? We have 3 types of ketone bodies in our body: acetoacetate, beta hydroxybutyrate, and acetone. We will talk in detail how these ketone bodies are formed in diabetes. So ketoacidosis or ketosis will result from increased mobilization of fatty acid from adipose tissue. Remember, if we have insulin, we're going to tell the body to stop breaking fat, to stop mobilizing the fat that we stored in our adipose tissue, because insulin is anabolic. It's the time to store, not to break. If we don't have insulin, the signal is lost, and therefore there will be increased mobilization of fatty acids from adipose tissue. And also there will be accelerated hepatic fatty acid beta oxidation, which will lead to the formation of hydroxybutyrate and acetoacetate. So diabetic ketoacidosis, abbreviated as DKA, occurs in 25 to 40% of newly diagnosed type 1 diabetes and can reoccur if the patient becomes ill, like if he has an infection or if he's not taking the treatment. So why all this fat mobilization lead to ketone body formation? Because what is the product of fat breakdown? Acetyl-CoA. This acetyl-CoA should enter the Krebs cycle, but if we have too much acetyl-CoA, what will happen? This acetyl-CoA will be converted to ketone bodies. Even with that, not all the fatty acids will that are broken down will be made into ketone bodies. We will have excess fatty acids which will be converted to triglyceride and which will be packaged into VLDL.